Hello, 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 ladies and gentlemen, hello. So, we are talking today about therapeutic communication. For exam number one, there will be three questions from this PowerPoint, and for the cumulative final exam, there will be only one question from this PowerPoint. So, there are a few professional and regulatory agencies that will stress the importance of good communication. And one of those is the Joint Commission, The National Patient Safety Goal number 2, that has been effective since 2020, aims to improve patient safety by improving communication among caregivers. So the Joint Commission Speak Up campaign performance standards will state that patients have a right to receive effective, understandable information and the right to have a language interpreter if necessary. So the National Academy of Medicine, the NAM, values patient-centered care by communicating in a way that will respect patients' differences, their values, preferences, and expressed needs. The NAM will focus on providing patient education to foster informed decisions, promote involvement in care, and enhance health maintenance and healing. And since patient education is one of my passions, it will become very important to you. The National League for Nursing, the NLN, will promote excellence in nursing practice with core values for caring, integrity, diversity, and excellence. Open, clear, and respectful communication is the foundation for nurses providing quality care that will contribute to patient well-being. So, what is communication? Communication is a dynamic, reciprocal process, reciprocal meaning me and you, or you and another person, of sending and receiving messages using words, sounds, expressions, body movements, written symbols, and behaviors. So communication will form the basis for sharing meaning, expressing needs, and building effective working relationships among individuals, families, and the other members of the healthcare team. So communication is more than just the act of talking and listening. So communication will occur on many levels. Interpersonal communication is conscious internal dialogue, sometimes known as self-talk. So, for example, you find your patient pale and diaphoretic. Diaphoretic is the fancy word for perspiring, sweating profusely, and moaning. You may think to yourself, what is happening? My patient appears to be in pain. Constructive affirmation or positive self-talk, I can do it, promotes success in a task, as opposition to negative self-talk. I can't do this may adversely affect a person's ability to complete a task. And ladies and gentlemen, let me just say this, that when you are indulging in self-talk with yourself, as you may do before you go in to do a task, or as you may do before you come in to take an exam or come to class or whatever it is you're doing. Whatever you say to yourself is going to be true. So if you say to yourself, I can do this, I can attempt to do this, I will try my best to do this, well, then that's what's going to happen. If you promote negative self-talk within yourself, I will not be able to do this, well, then you're right. You will not be able to do it because you tell your brain what to do. So interpersonal communication is communication that will occur between two or more people. Nurses use interpersonal communication to gather information during assessment, to teach about health issues, to explain care, and to provide comfort and support. So professional nurses will communicate with other nurses and then other members of the healthcare team to provide comprehensive care for clients. So, group communication. Group communication will occur when you engage in an exchange of ideas with two or more individuals at the same time. So examples of small group communication will include staff meetings, committee meetings, educational groups, self-help groups, and maybe family teaching sessions. And then public speaking. Nurses make presentations to various size groups to educate people about health issues, to lobby for health legislation, and to address colleagues at professional conferences. So, communication involves content. The content of communication is the actual subject matter, words, gestures, and substance of the message. It is the message that everyone can see and hear. For example, the client states, "I slept through lunch." Well, this content, this statement is really open to interpretation. It does not relate whether it was a good thing because they needed the rest or a bad thing because they missed lunch and now they're hungry. So I slept through lunch, that could be taken both ways. All right, we need a little bit more clarification there. So communication is a process. So process will refer to the act of sending, receiving, interpreting, and reacting to a message. The sender, which is the source of the message, will use verbal and nonverbal methods to deliver a message, meaning the content, to another person. Encoding refers to the process of selecting the words, gestures, tone of voice, signs, and symbols used to transmit the message. The message is the verbal and nonverbal information the sender will communicate. So, the message must be appropriate for the situation and for the developmental level of the person that is receiving the message. So, what does this mean? This means that it needs to be an appropriate topic. The content needs to be relevant to the topic. And I need to use words, terms, literature that is at the developmental level of my patient or my client or the family member, whoever I am giving this information to. It cannot be above their level of understanding because then, of course, they won't understand it. So, the channel is the method in which the message is conveyed. Nurses may use touch as a nonverbal way to communicate caring and concern. Then silence. Ladies and gentlemen, please do not dismiss silence. Silence is totally appropriate. It is totally well within your purview. Sometimes people just want to be heard. So if your patient is venting, if they are upset, they may just want to verbalize, they just may want to be heard, in which case your silence will be golden. Sometimes, as in comforting a patient, silence is not always awkward. Sometimes silence is appreciated. I don't need you to talk to me. I don't need you to comfort me. I just want you to sit with me and be silent. Be supportive in that way. Do not dismiss silence. The receiver is the observer, listener, and interpreter of the message. The receiver will interpret, meaning decode, by relating the message to past experiences to determine the sender's meaning. So feedback may be verbal, nonverbal, or both. So verbal communication. Verbal communication is the use of spoken and written words to send a message. It is influenced by educational background, culture, language, age, gender identification, and past experiences. It is generally a conscious act in which the sender will choose the most effective words to communicate their message. The goal of a verbal message is for the receiver to understand both the words and the meaning behind the words. So that is my goal. I am going to say something to you. I am going to impart some information to you. And hopefully, I am going to use the right words, the right terminology, the right facial expression, so that you will understand what I am saying. Vocabulary. Healthcare workers have a large vocabulary of technical terms and jargon. And ladies and gentlemen, if you have gone through medical terminology, you know that this is true. So when we say to our patient, you need to be NPO after 2400, I'll be in to prep the op site at 0800. You'll need to void before your pre-med. We will then transfer you to a stretcher and take you to pre-op. Well, someone who is not familiar with healthcare, who is not familiar with the healthcare system, they don't understand what they're saying. They're going to say, excuse me, I don't know what you're saying to me. I don't know what the expectation is. Or they may be a little embarrassed, like you're coming in to give me this information and I'm sorry, but I don't understand it. But I'm a little embarrassed that I don't understand it, so I'm not going to ask for clarification. So use medical terms only when you are certain that the listener will understand them. Otherwise, using plain layman terms is more effective. Ladies and gentlemen, you will also get this when you begin going to clinical. There are going to be many times where you are listening in for a bedside report in the morning, and the nurse may be using many, many terms or a lot of terminology that in the beginning you may not understand. And so our job, my job, if you will be to help you understand those terms a little better. So denotation and connotative meaning. Denotation is the literal meaning, the dictionary meaning of a word. Now, there are many people that are what we term literal, meaning that if I say something in jest, they are going to take me literally at my word. They may not stop to think, oh my gosh, does she really mean that, or is she kidding? So we call them literal people. And so if the person that you're speaking to, if you suspect that they are very literal, or if you know that they are very literal, then you need to be very careful in your terminology. Connotation is the implied or emotional meaning of the word. So for example, if a mother says to her child, "Don't cry, baby," a spouse may say to the other spouse, "Would you get me something to eat, baby?" Well, we know that the other spouse is, at least as old as they are. So in that respect, baby would be a term of maybe endearment. So the denotation meaning of baby is a very young child who is unable to walk. The connotative meaning is different in each statement. So please use terms that will provide clear, objective data and are not open for misinterpretation. And then pacing. The pace and rhythm of the delivery can alter the receiver's interpretation of the message. Sometimes when we are talking with our patients and we may be talking about a topic that is uncomfortable or a topic that I really don't want to talk to my patient about, or a topic that I am not exactly sure of. I have very limited knowledge about this topic, but I have to talk to my patient about it, and I don't have time to go into, investigation. So I'm going to go in, I'm going to talk about this really fast because I'm uncomfortable, and then I'm just going to leave. I'm just going to get it. It's like ripping off a Band-Aid. I'm just going to get it over really quickly. That is not helpful to your patient. So the pace must be slow enough for the receiver to interpret one thought before the sender moves on to the next thought, and should be fast enough to maintain the listener's interest. So it's sort of like me up here, where I have to move from topic to topic in a pace that I'm still hopefully holding your interest, but not so fast that you really don't understand what I'm talking about. And then intonation, excuse me. Intonation, simply put, means tone of voice or intonation. It will reflect the feeling behind the words. So this has a lot to do with the way we speak. And sometimes we don't really understand, or we really don't recognize that when we're speaking to people, we really don't have an inflection or a tone in our voice, right? We don't recognize that about ourselves. And many times it can be in a parent-child relationship where the parent may say to the child, "Do not speak to me in that tone of voice." Sometimes the child does not understand that they have a difference in their tone of voice. They're going to say, "Well, I'm just speaking to you," or "I'm just talking to you. I don't have a tone in my voice." And we know, if you're a parent, you know very clearly that there is a tone in their voice. So we have to consider pitch, whether it is high or low. Something we call cadence, and that is the rising and falling of the pitch. And hopefully this is something that when you're talking to your patient, or me myself, the pitch in my voice is so that it is not monotone, and hopefully I can hold at least a little bit of your attention. And then the volume, whether it is soft or loud. I am told that out of everyone here on campus that will come in and teach a class, I am probably the only one that will ever have to use the microphone. And I think that I have a very loud tone of voice myself, but I'm told that I do not. So people tend to tune out when someone speaks in a monotone, meaning there is no inflection, no cadence. So clarity and brevity. So a conversation that is clear and brief holds the interest of all parties and effectively conveys the intended messages. Clarity requires two things. One, that you select words that will convey your intended meaning, and two, that you make sure your spoken words and the nonverbal language send the same meaning. So if there is an inconsistency, and you may see this with your patient, where you go into your patient's room and your patient is visibly upset. They may be weeping, they may be pacing in the room, they may be wringing their hands, they may be sitting forlornly looking at nothing or out the window, and you say, "Oh my gosh, Mrs. Smith, are you okay? Is there anything I can do?" And she looks at you and says, "Oh no, I'm fine." Well, clearly she is not fine. Clearly she is not. So there is an inconsistency between what she is saying and what you are seeing. So brevity can be achieved by using the fewest words possible. And then timing. When you are talking with someone, timing is crucial. So before you start your conversation, assess your client. A client that is unable to concentrate because they are in pain, they may be hungry, they are distracted, will not receive the message as it was intended, as you are sending this message out, because the timing is off. They are distracted by something, and they are not going to hear or understand what you are saying. Timing so we need to consider the presence of others. If you ask a client about a personal issue in the presence of others, you may receive a very different response than if you had asked the question in private. So interaction must allow ample time for a response. A rapid flow of questions is a one-sided conversation that will inhibit the interaction. So if I'm speaking with my patient, or if I'm speaking with anyone, and I ask a question, and if I don't give an appropriate response time, and please, ladies and gentlemen, when you are speaking with your patient, and they are talking with you, please respond to them. Please respond to them, even if it is only to say, yes, I'm listening, or yes, I'm here, or a simple yes. Because otherwise what happens is they're going to say, Deb, and I'm going to wait for the next sentence because, yes, of course, yes, I'm listening. Well, I know that I'm listening, but my patient may not know that I'm listening. So what's going to happen is that they're going to approach me again, Deb, and then, I'm like, well, okay, I'm listening. Make your statement, keep talking, but I haven't acknowledged that I've heard them. So what is going to happen? There's going to be frustration on my part, frustration on the other person's part, and what I'm going to get is, yo, Deb. And I'm like, yes, yes. And so now I am going to answer in an annoyed tone of voice, yes, I'm listening. And the other person is going to be very frustrated. And the first thing they're going to say is, well, I had no idea that you were listening because you didn't respond to me the first 2 times. You understand? And then relevance. So when teaching your client about this medication, begin by reminding him of the purpose of the teaching session. So communication is effective when those involved find the discussion to be important. It has to be relative. It has to be important to them. So, credibility. Patients judge the credibility or the believability of the message by the trustworthiness of the sender. So this means that my patient has to have some form of trust in me so that when I go in to say something to them or instruct them on something, that they will believe me, that they will trust me. So always be open and honest with your patients. When you unintentionally offer unrealistic reassurance, the patient may feel that you are not being honest and genuine, such as, I know, and we say this all the time, the patient is getting ready to go to surgery, or the patient is going to get ready to go for a test, and they're very apprehensive over the result, and we say, oh, don't worry about it, you will be just fine. And although we think that we are being reassuring to our patients, we really are not, because I really have no way of knowing unless I'm basing it on another previous test result that I've already seen that they may or may not be aware of, that they are going to be just fine after this procedure or after this exam. I really don't know that. So you may need to change your phraseology a little bit. To say, you know what, let's just try and be positive and let's think positively that everything may be okay. You might have to change your wording a little bit. So give information only if you are certain of the facts. A response such as, I don't know, but I will find out for you, is a much better response than an incorrect answer, a guess, or an opinion. Your patient will respect you a lot more if you say, you know what, I don't have that information right now, but let me get that information from someone who I know has the information, and I will get back to you. Rather than, pulling pulling an opinion or what you think may be the proper information, out of the air. So if a situation makes you uncomfortable, it is better to acknowledge your discomfort than to risk loss of credibility. If your discomfort is because you need more information or facts, a more honest approach would be to acknowledge that your patient's diagnosis is a serious matter. It is a serious matter. If you are uncomfortable addressing your patient's fears and feelings, you can offer to find someone more experienced to assist the patient. So to be credible, your body language must be consistent with your spoken words. So if your patient is talking to you and they are using words that you are not yet familiar with or you have not learned about yet, then the best thing you can do for yourself and the best thing that you can do for your patient is to say simply, you know what, let me find someone who has more knowledge about this than I do. Or perhaps let me get you some paper and a pen or a pencil, and let's write this question down so that when the physician comes in, when doctor comes in, we can ask him this question. This way, they will respect the fact that, you know what, she doesn't really have all the answers, but she's going to help me. And so if it is something that you are uncomfortable about, whether it's a diagnosis that may have touched you or a family member and it is making you uncomfortable, all you need to do, maybe you don't want to share that with your patient because clearly they're going to see that you are uncomfortable. What you can say is, you know what, let me find someone who you can talk to about this. You don't have to say that it's not you. You don't have to say that. All you have to say is, let me find someone that you can talk to about this. And then nonverbal communication. As nonverbal communication emerges from feelings on a more unconscious level, your patient's body language, including posture, gesture, movement, facial expression, and eye gaze, can tell you how they are coping with what they are hearing and how they are processing the information. So, your body language is going to be equally important when you are talking with your patient. When speaking to your patient who is sitting or lying in bed, it will be helpful to sit on the side of the bed or to be at eye level rather than speaking from an elevated standing position. So, especially if it is a topic that is very sensitive, or if you have just come upon your patient after they have been given maybe a diagnosis or some news that is not exactly good from a physician, it is quite acceptable. It is recommended. I encourage you to do it. If you are uncomfortable sitting on the side of the bed with the patient, pull up a chair. Pull up a chair, sit next to the bed, and just simply say, how can I help you? Do you want to talk about this? Or again, do not be afraid of that silence where, you know what, I don't really know what to say, but let me just sit here with you in case there is something you want to say. And I am just going to support you just by being here. This can put your patient at ease and help to form a genuine connection, just sitting with your patient. Sometimes when we are standing by the bedside and we are looking down at a patient, it kind of sort of resembles like the alpha dog thing where, I'm lording over you. And no, that is not the impression that we want to give to our patient. Facial expression, movement of the face, and especially the eyes are the most obvious forms of nonverbal communication. So facial expressions will communicate joy, anger, sadness, concern, interest, skepticism, apathy, or fear. So a mismatch between your verbal message and the facial expression may be confusing or cause the client to doubt your credibility. So, Posture and gait. Body position, your gait and posture will offer clues to a patient's attitude, emotions, physical well-being, and self-concept. Personal appearance will provide clues to a person's feelings, socioeconomic status, their culture, and perhaps their religion. Nurses must consider how patients perceive them and whether their appearance helps or hinders patients' relationships. And then gestures. Hand and body gestures emphasize the clarity of the spoken word. They are good indicators of the feeling tone behind the words. Gestures will vary among individuals, so use them with caution. They are easy to be misinterpreted. They can assist with communicating with individuals with impaired communication. Touch can convey affection, caring, concern, and encouragement. So, factors that will affect communication. One of them is environment. Communication is most successful in an environment that is quiet, private, free of distractions, and at a comfortable temperature. To discuss private matters, the location for conversation should allow patients and their families to hear important information. Older adults may be affected by sensory alterations, such as hearing loss or vision changes or other healthcare problems that may affect cognition and expression, such as dementia. Gender will affect communication. Every patient or family interaction is unique. There is no one-size-fits-all approach with respect to gender. Patients and people have different life experiences that will affect gender identity, gender expression, and their sexual orientation. So patterns of communication are person-specific, not necessarily gender-specific. So to create a caring and gender-affirming environment for all individuals, use inclusive gender-neutral language. So address the health problem. You don't want to address the person. You want to address the problem, the health problem. Ask patients about their preferred gender pronouns and use them consistently. It is not inappropriate to ask a person how they want to be addressed. That is not inappropriate at all. It is very respectful. Ask patients about their preferred gender pronouns and use them consistently. Listen to and reflect patients' language when describing their own sexual orientation and how they refer to their relationships or their partner. So, for instance, if someone refers to their partner as their significant other, or if they refer to them by name, then that is how you need to respect and then refer to that person with that same terminology. Reflect on your own personal biases, preconceptions, and areas for growth. And then, regardless of gender, be aware of the fact that the patient and the nurses may express or interpret the same message differently. So again, it comes back to good communication and using terminology and using a facial expression and being understood by the person that you are speaking to so that they are receiving the correct message. So, personal space. People vary in the amount of physical space they prefer when communicating. So people will engage in personal conversation and they are typically 18 inches apart, 1.5 feet, although it depends on individual preferences. It is also at this distance that body contact can occur. So as a nurse, we invade my my patient's personal space when I have to perform an assessment or a procedure, or when using touch to offer support, right? So you need to know that, yes, I can invade your personal space. Before providing nursing interventions in the client's intimate space, discuss what you are about to do. So when you walk into the room, of course, you're going to have a conversation with your patient. How are you doing today? My name is Deb. I'm going to be your nurse, or I'm up here working with the nurses today. And so I have your meds outside the door, but before I bring in your meds, I would just like to assess you, very quickly. So can I listen to your heart and your lungs? Can I start there? So it is pretty much, when the patient is in the hospital, it is pretty much the expectation that everybody that walks in the room is going to be performing some sort of assessment on them. With most patients, that is the expectation. However, it is still very respectful to let the patient know what you are going to do before you are going to do it. It is best to ask the client's permission, even for gentle touch, if there is the slightest doubt about the client being receptive. So personal space is typically from 18 inches up to 4 feet. Interactions with clients and healthcare team members will commonly occur at this range, anywhere from between 18 inches to 4 feet. So if I'm just coming in and I just want to have a conversation with you, or if I'm just checking back very quickly and saying, hey, I gave you your pain medication about an hour ago, what is your pain level now? I don't really need to get up to that 18 inches, it's really not necessary. I can, just stand inside the room, maybe 3 or 4 feet back, and say, so are you feeling any better? Is there anything that I can do for you? You really don't need to really get up that close to them. This distance will facilitate sharing of feelings or personal thoughts and is appropriate when communicating caring or concern. Again, that 18 inches up to 4 feet. So social distance is generally between 4 and 12 feet, right? Socially acceptable. And then public distance is considered to be beyond 12 feet. So I know that we've already talked about this, but we're going to talk about it again, and we are going to be talking about it the whole time that I'm with you from this semester, also going into next semester, and that is assessment. Assessment is essential to effective communication. The nurse should assess the 4 factors that will alter a client's ability to receive, process, or transmit information, such as a developmental delay, physical and cognitive impairment, and if they are under the influence of a substance. And then analysis and nursing diagnosis is communication can be the problem, or it can be the etiology. Etiology means beginning. Where did it start? Or it can be the beginning of a nursing diagnosis. So communication problems may involve the inability to receive, interpret, or express spoken, written, and nonverbal languages. So, for example, readiness for enhanced communication is recommended when the client expresses willingness to enhance communication that is already effective, meaning that I have just spoken to my patient about insulin, and they have expressed to me that they want to learn about different types of insulin, or different times to take their insulin, or different ways that the insulin may work, right? So readiness for enhanced communication is recommended when the client expresses willingness to enhance their communication skills. So ladies and gentlemen, listen up, and then listen up one more time for me. Impaired oral communication. Impaired oral communication is an appropriate diagnosis if the client has 2 things. 1, expressive aphasia, or a physiological problem such as dyspnea, which is shortness of breath, stuttering, or laryngeal cancer that impairs the ability to speak. So there is something that is going on that is impairing their oral communication. There is something that is getting in the way of them speaking or speaking clearly. Receptive aphasia or sensory deficits that impair the ability to receive messages, or they do not have the ability, impaired oral communication is they do not have the ability to speak, or there is something going on receptively. Perhaps they had a stroke. Maybe they have a mass in their brain. Perhaps it is a cognitive or developmental delay where they cannot receive what I am asking them to do. So I'm asking them to go across the room and pick up their shoe. They can't do that because they don't have the receptive property. And then just impaired communication is the preferred diagnosis if the client is unfamiliar with the dominant language or has some other difficulty receiving or sending messages. So if you have a client where their predominant language, their first language is Spanish or Asian, that is not impaired oral communication because they can speak. I can't understand what they're saying because they may be speaking in their native language. So that is not impaired oral communication. It is simply impaired communication because they know what they're saying. I don't understand what they're saying. So they do not have a dominance over the English language. So that is just simply impaired communication. So etiologies of communication diagnoses, ladies and gentlemen, please continue to listen up. Assessment data will help determine whether communication impairment is the primary problem. They had a stroke and they can't speak, or whether it is a result of other health problems. Some nursing diagnoses may cause or contribute to communication problems. For example, acute or chronic confusion may cause difficulty expressing or receiving verbal and nonverbal messages. So confusion may be related to a physical or a mental health problem, maybe a side effect of a medication, or if they are psychologically impaired, such as a manic disorder, they may be sleep deprived. So mental health problems can also lead to communication problems. For example, anxiety will impair the ability to deliver and receive messages. If you are so anxious, when you come to clinical, if you are so anxious, if you are so nervous, that is going to be a very big barrier, a huge barrier to me trying to educate you, because you're going to be so anxious, you're not going to hear what I'm saying. Chronic or situational low self-esteem often results in limited interaction of others. So, if you feel badly about yourself, you are not going to want to interact with others. So that is going to be a huge barrier to communication. So impaired verbal communication may be the etiology of other nursing diagnoses. So, for example, anxiety related to the inability to communicate their needs. Impaired social interaction related to the inability to carry on a conversation. Chronic low self-esteem related to the fear of conversing with others, secondary to stuttering. So, planning outcomes and then evaluation. Ladies and gentlemen, listen up, and then listen up one more time. Individualized client outcomes and goals will depend on the nursing diagnoses that are identified. For example, for impaired verbal communication, the following desired outcomes may be identified. Uses alternative methods of communication, such as writing, a picture board, gestures, effectively. So, someone who has had a stroke or someone who is unable to communicate, if there is an impaired ability to communicate, maybe they can't speak, but they can use an alternative method to communicate with you, such as the picture board. I can't speak it, but I can write it. They will demonstrate minimal frustration with communication difficulties. That could be a wonderful outcome. Willingness to discuss fears and concerns with their nurse. So, unless my patient trusts me, unless there is the beginning of that nurse-patient relationship that is so very, very important. If my patient does not trust me, there will not be a willingness for them to share their fears or share their concerns. So, for example, I go in and see my patient after a doctor has been in the room, and I may or may not already know what doctor has already discussed with them. So when I go in and follow up with my patient and see my patient, they may say, oh, no, I'm fine. Well, I know gosh darn well they're not fine. They are just not ready to speak to me. They are not ready to share with me yet what is going on with them. They don't want to share their concerns or their feelings quite yet. So that may be a goal that I devise for them, that they may at some point be willing to share with me so that I can somehow offer assistance as to how to help them. Communicates effectively using a translator or an interpreter. Interprets messages accurately as evidenced by appropriate verbal or nonverbal feedback. So planning interventions, the implementation of the care plan. Specific nursing activities for communication problems will depend on the etiology of the problem and the goals selected. So, the focus of nursing interventions is to facilitate communication and to resolve or reduce the factors that are interfering with it. Standardized interventions for impaired verbal communication are active listening, assertiveness training. Communication enhancement, meaning hearing or visual deficit, or presence and touch. So addressing the patient, ask your patients how they would like to be addressed. So for patients who aren't able to respond, it might be better to ask a family member or another caregiver who has taken care of the patient how to address them. This conveys respect, which is essential to a therapeutic relationship. And then active listening. An active listener will use all of their senses to focus on the sender's message and allows the sender the opportunity to complete comments without interruption. So, ladies and gentlemen, please listen up, and then listen up one more time. Establishing that trust. Honesty and disclosure cannot exist without trust. Mutual trust is an essential component of professional and therapeutic communication. So as trust grows, the client can more easily relay information and share their feelings, but they have to be able to trust me. And then being assertive. An assertive person can express themselves effectively and directly communicate their point of view while still respecting the viewpoints and beliefs of others. Because assertive communication is based on mutual respect and freedom to confront difficult issues, the therapeutic relationship is a safe place for clients to convey their needs and concerns without feeling judged. So when my patient expresses something to me, they cannot feel as though I am judging them. It is not my place to judge them ever. It is not my place to judge anyone ever. So, for enhancing therapeutic communication, restating, clarifying, and validating messages. These 3 techniques will help to identify clients' concerns and focus on communication. So restating means using your own words to summarize the message you just received from the client. So my client is going to tell me, I don't know, about what they had for breakfast, and I am just going to briefly relate back to them. So for breakfast, you had some scrambled eggs, you had some toast, and you had some fruit. Is that correct? So I'm going to restate it in my own words. Clarifying messages will help to ensure that the information has been accurately interpreted, and then validate the message by asking the client whether you are making the correct interpretation. So after I say you had some scrambled eggs, some toast, and some fruit, I'm going to say, so is that correct? Right? So I'm going to clarify what they just told me. And then I'm going to say, so just to be clear, you just had scrambled eggs, some toast, and some fruit. So I'm validating. So ladies and gentlemen, please listen up, then listen up one more time. Interpreting body language and sharing observations. Be attentive to what the patient says and how they say it. Be attentive. Note their tone of voice, their rate of speech, their distance from you. Are they leaning towards you? Are they reclining back? Are they moving about the room to get away from you? Eye movement, facial expressions, and gestures. If the spoken and the nonverbal messages are mismatched, this needs to be addressed, perhaps not in that moment. So, if I am talking to my patient and if they seem upset, they are walking about the room, they are not looking at me, they are wringing their hands, maybe they're a little weepy, maybe they're looking for tissues, and if I say to them, are you okay? Can I help? And they say, oh no, I'm fine. Well, clearly there is a mismatch there. So what I am going to do is I am going to tell myself that I am going to come back, I am going to revisit this. It is not something that I am going to pressure in the moment. Exploring issues. Ask open-ended questions to obtain a clear understanding of an issue, and then follow your client's thoughts, meaning let them lead the conversation. So ladies and gentlemen, please continue to listen up. Using silence, again, I have to say, do not be fearful of silence. It is a wonderful tool. Learn to be comfortable with silence, especially when your client is emotionally upset. Silence will demonstrate acceptance, and it will allow the client to organize their thoughts to provide further information. And then summarizing the conversation. At the end of the conversation, summarize what has been heard, what you heard. Summarizing will demonstrate active listening and allows the client to clarify any misunderstandings. So ladies and gentlemen, thank you very much for your time and attention. And please, if you have any questions, comments, concerns, please feel free to reach out. Thank you, and I thank you again for your time.